issues. If it is licensing of healthcare workforce, it will be done by a different institution. Accreditation and inspection of facilities, then let it be done by somebody else different, so that we don't have to mix all this, which is bringing a bit of problem. We already have institutions that are in charge of healthcare workforce. The doctors have their KMPDC. The nurses have Nursing Council, the clinical officers have the Clinical Officers Council, and any other cadre, they also have their own councils, including Nutrition Council. So coming back to the facility, I know I may not want to delve into that case, because it's already a case under investigation, and it would be very disrespectful if I start discussing matters of security in a national TV when we do not have the report. I would ask you and our viewers to be patient so that we can get the report, and then we can be able to discuss or dissect what went wrong, what can we do moving forward. Yes.
If we, I mean, before we leave this space where we're talking about the safety as well as the quality of healthcare, just how deeply engaged are the unions, as you have mentioned, in terms of forming this bill, or perhaps in terms of, just giving proposals or them voicing their concerns? Because it's one thing, and it's very common, especially with the health sector, where, we get to see policies that have been projected, and then later on, you invite these unions, you invite, health specialists on board, and they're like, we said we gave our proposals, but, the ministry decided to just sweep them under the carpet. So how involved are they, and just how much can you guarantee them that their proposals are going to be put to consideration?
No, we are working very closely with them. In fact, the last meeting was between the Ministry of Health and the healthcare cadres, and we are in agreement that we need this bill. We need to move forward. We need to protect the patient. You see, just like we are talking about, I know you have seen on TV recently when we are talking about bed capacity, that we have facilities who are registered as maybe a level 4, and your bed capacity is maybe 300, but your admissions go up to 1,000. You see, so that means there are people who sleep on the floor. So these are the kind of standards that we are talking about. I don't think you will be happy if you went to a facility and found your mother sleeping on the floor. And probably that facility will still charge SHA to pay for that.
And I'm glad that you bring that up, because, of course, yes, the non-bed sharing policy is one of the questions that I wanted to ask tonight. So how does then the ministry intend to build capacity, that is at both county and national hospitals, to ensure that the policy is enforceable across, even though we understand that health is a devolved function? Just how are you working in synchrony with the counties?
We do not have patients for counties and patients for national government. A patient is a patient. And when you talk about the roles of national government and county government, they are very clearly stipulated. The national government role is to develop policies and training, and the counties implement. In fact, most of the facilities are at the county level, so implementation works there. But we still have the role of oversight. We still have the role of inspection. We still have the role. So it's up to us to up our game and ensure that those facilities are meeting the standards. And if they don't meet, then we close them. It's as simple as that. But so far, so good.
So far, so good.
So far, so good. I know you want to know, and you gave me this at a before we started, and you wanted to know what exactly have we been able to do for those 3 years that we have been in existence.
Hold it. We're going to come to that. We're going to come to that. We really are going to come to that. So I want us to ask this question, which is in relation to what we've just discussed.
Maybe the questions you're asking me are going to be answered by that.
But now.
So you'd rather allow me to talk and tell you, and then you can ask me the question.
It's a question answer affair. I'll come to that. You see, they say that many hospitals, because we're talking about beds,
Yeah.
I don't know whether you're alive to this reality that today in many hospitals, you see that the beds are empty, it's vacant because the patients cannot afford. And I really wanted to avoid the question of SHA, but you have mentioned it a couple of times. The president today has spoken about the fact that SHA is working. I don't know whether that's the report that you're giving him and whether this report resonates to what it is that is on the ground. That today we really are seeing patients going home simply because they cannot afford the full 1 year payment of SHA. My own mother sent me actually not sent a message before she even knew that I'll talk to you. She was like, well, this 1 year thing, you know, sometimes you pay for different people who are actually not working. How are we going to make sure that we keep this money until we make an annual payment? You know, most of us, you know, are hand to mouth kind of people. So when you get your 300 bob, your 500 bob, you want to remit it almost immediately. When you're trying to remit, you're told you cannot do that. You need to do this annually. How do we ensure that, you know, the patients do not end up suffering at home and that every other Kenyan, regardless of their levels of cadres, or, you know, are met, their concerns are met?
Thank you for that question. And I want to confirm to you SHA is working.
Okay.
And if we have to go granular, we need to go to specifics. That so and so went to this facility, the facility's name is this one, and this is the experience. Secondly, we listened to the pain of Kenyans. Even that 1 month paying, some people could not afford. And that is why we introduced the SHA, Lipa SHA Pole Pole.
Okay.
Many patients would go to hospital. Maybe you're from Mjengo or